Is it just me, by the way? Like, when it comes to Halloween and stuff, I can't help but look at the skeleton costumes and just wonder how they got the anatomy so wrong. Is that really weird? I think it might be, but I just can't help it. Like my son, he just bought a skull, and I just kept looking at it. It's so incorrect. Like, what is that? Like, those are the wrong suture lines. Everything about this is just wrong. But yeah. Anyway, me just being weird, I guess. So well, no, I'm not the only one then. Good. So then let's have a look at this one. So this is yeah, or like wrong number of ribs, like everything's just wrong about it, like all of it. Okay, so then we have a look at this hand, and normally what you do is you'd be looking for the metacarpal necks, right? So the metacarpal neck is very, very common to get a fracture, and definitely the fourth and fifth because people, they don't know how to punch properly. And they end up getting the translation of forces in completely the wrong place. But this one doesn't look bad at all. There's no fracture. Then you'd go to the bases as well and just make sure that looks okay. And I'd really zoom into these because sometimes you get a bit of overlap. You're not entirely sure. And I genuinely try and draw around it as well, just to be sure that you can see that there is no abnormalities there, right? So what have we got? We've got the scaphoid, you got your lunate, you got your hamate, you got your trapezium that goes to the thumb, you got your trapezoid, you got your capitate. Oh, no, that's your hamate. And so that's your triquetrum. Yeah. Some lovers try positions they can't handle. So that's your anatomy there. And then what you need to do is you zoom into the kind of more lateral view and just try and see if you can identify the bones and then maybe even find the fracture. So yeah, someone has said, a few people said triquetral, and that's not a bad shout because generally speaking, if you see a fracture in the dorsal aspect of the wrist, most likely it is going to be a triquetral fracture. But I think on this one, if we draw it, so that's your scaphoid, that's going to be your lunate, that's going to be your triquetrum. That's going to be your trapezium to the thumb. Your trapezoid is somewhere there. Your capitate is probably somewhere there. And then over here, you've got your hamate, and it looks like there's a bit of a jagged edge there. Can everyone see that? So I'd actually go with a hamate fracture on this one rather than the triquetral fracture, but I completely understand why you'd say that. Now, someone has said that they felt there could be an enchondroma. So it's not very usual you get an enchondroma within the carpal bones. I mean, nothing's impossible, and it can happen. But there isn't really, if you're talking about this radiolucency, that's more going to be because of the way the actual triquetrum is, it kind of curves around a bit, right? But if you look here, there's no lesion within there at all. So I wouldn't go for a enchondroma or anything like that. This is going to be most likely, there's going to be a hamate fracture. And you can see there's probably going to be a bit of articular surface involvement as well. So now we know that. Let's have a look at the other view. Oops. Let's erase that. Wait, if you double click, you make a circle. Why is that? Anyway, I don't think you can really 100% see it on this view, can you? The oblique views really helped us here to be able to find it. Without the oblique view, I don't think it can. I don't think anyone can see that. I'd be surprised if anyone's going to be here and say they can see a fracture there. But yeah, undoubtedly, with the radiology rapids, they say that if you can show the fracture and everyone's like, "Yep, there's a fracture," then they put that into the exam. And I would say that that is going to be like, yeah, you can't. There's no denying that. That's definitely a fracture. Detecting scaphoid fractures can be very, very difficult, very, very difficult in some patients because sometimes they're non-displaced and so sometimes you can't see it. So what you end up doing is doing another X-ray in like 2-3 weeks time or something just to see whether there's any callus formation. And even then, sometimes it can be difficult. The patient's still complaining of pain. Ultimately, an MRI scan is probably the best way forward. I have seen people do CT, but I personally find that MRI scan is probably visually anyway easier to see because you just get a whole lot of edema. There's no doubt about it. CT can be a little bit hit and miss. But yeah, usually when you're detecting scaphoid fractures, it's usually going to be like a follow-up X-ray if you're not going into sort of higher, what do they say, higher complex imaging like CT and MRI. If you're just going to go with plain films, you just do repeat. Right. And again, it depends on the patient's symptoms. Like if the patient's like, look, I'm seriously in a lot of pain, it's not getting better, then you know what, just get a CT or get an MRI. Not worth it. Okay, as in it's not worth them going through pain for no reason, right? It's better just to find out. I mean, I would want to, wouldn't I? And so would you, I assume.